Good afternoon, everybody. Today's webinar is on gastroesophageal reflux disease, that is GERD. I'm Dr. Jaisingh Shinde. I'm a laparoscopic surgeon practicing and endoscopic surgeon practicing at Pune for last 30 years. Acidity, hyperacidity are the commonly used terms in the colloquial language to describe the condition which we medically called as gastroesophageal reflux disease or abbreviated as GERD. GERD is a very common disorder seen by surgeons as well as physicians, including the general practitioners. Today's talk, I will try to answer some of the questions that GERD raises. One is definition of GERD, epidemiology of GERD, pathophysiology of GERD, clinical manifestations, diagnostic evaluation, treatment, medical and surgical, why surgery should be done in GERD patients, and what are the complications after surgery for GERDs. As a matter of fact, there is no gold standard definition of GERD. GERD is a multifactorial process involving physiological and anatomical abnormalities. But for convenience of uniformity, the Montreal Conscious Meeting defined GERD as a condition which develops when the reflux of stomach contents causes troublesome symptoms and/or complications. Symptoms are considered troublesome if they adversely affected an individual's well-being. What happens in GERD? There is loosening of the lower esophageal sphincter, which allows gastric acid to splash into the esophagus, as you can see on this picture. Reflux stomach acid touches the lining of the esophagus, causing a burning sensation, also known as heartburns, acid reflux, indigestion, and acid regurgitation. So these are the complaints that patient usually presents with. From a surgical perspective, GERD is the failure of the anti-reflux barrier, allowing abnormal reflux of gastric contents into the esophagus. It is a mechanical disorder which is caused by a defective lower esophageal sphincter, that is LES, and a gastric emptying disorder or failed esophageal peristalsis. Before we go further, we have to understand what is transient lower esophageal sphincter relaxation. The gastroesophageal reflux per se is a physiological phenomenon which usually occurs during the postprandial period in most people. Up to 50 reflux episodes may occur in a 24-hour period, but most of these episodes are short-lived. Exposure of the lower esophageal mucosa to acid pH less than 4 should not exceed 5% of the 24-hour period. Gastroesophageal reflux in excess amount is considered pathological and leads to esophageal mucosal sensitization. This in turn contributes to the symptoms of the disease. Approximately 20% of adults have frequent classic symptoms of gastroesophageal reflux disease. In 10% of these patients, esophagitis may develop. 10% of these may develop complications like ulceration, stricture, and columnar metaplasia. And among these 10% will develop columnar metaplasia and develop dysplasia. So, gastroesophageal reflux can be physiological and pathological. When it is normal number and duration, it is called as physiological. When it exceeds the normal limit, it is called as pathological. So, physiological is one which occurs in response to swallowing. It is postprandial. It is short-lived, less than 5 seconds. Asymptomatic. No nocturnal symptoms will occur in physiological GERD. But when it is in excess, it occurs in absence of swallows, lasts for 30 to 50 seconds, symptomatic, mucosal injury occurs here, nocturnal symptoms also are seen, and it is associated with gastric distension. So, pathophysiology of GERD is complex. There is imbalance between aggressive factors from stomach contents, that is gastric acid and duodenal contents, and defective factors protecting the esophagus, that is anti-reflux barrier, esophageal acid clearance, and tissue resistance are the defense mechanisms which have failed. But normally, there are four major physiological mechanisms which protect the esophagus against acid injury, and they are the clearance mechanism, as you can see in this slide, then the mucosal integrity, the lower esophageal component competence, and the gastric emptying. So these four factors normally prevent reflux of gastric contents into the esophagus. We will see in detail how they achieve this. The esophagus clearance of reflux rate from the esophagus occurs as a result of volume clearance due to normal peristalsis of the esophagus in response to swallowing. Then chemical clearance occurs as a result of neutralization of the acid at the lower end of the esophagus by the saliva, which contains xylene. Mucosal resistance, the mucosal glands producing bicarbonate are probably important for neutralization of the acid reflux during sleep when salivary secretion is decreased. Now, coming to the lower esophageal sphincter, this is a high pressure zone located at the esophagogastric junction, and this has an important role to play in preventing reflux. There is no distinct anatomical sphincter, however. The length of this physiological sphincter is 3 to 4 centimeters long. It maintains a pressure of 10 to 25 millimeters of Hg, remains in a tonic contraction, and relaxes during swallowing, belching, and vomiting. The lower esophageal sphincter has three characteristics that work in unison to maintain the barrier function. These characteristics include the resting low esophageal pressure, its overall length, and the intra-abdominal length that is exposed to the positive pressure of abdomen. So these three factors are very important as far as the function of the lower esophageal sphincter is concerned. The resistance to the gastroesophageal reflux is a function of both the resting low esophageal pressure and the length over which this pressure is exerted. Thus, as the sphincter shortens, the higher pressure is required to prevent the given amount of reflux. This will be subsequently made further elaborated in the subsequent slide. Now, gastric distension also affects the competence of the lower esophageal sphincter. Approximately 40% of the patients of Gerd have impaired gastric emptying. Gastric distension exerts pressure against the physiological anti-reflux barrier, which causes shortening of the sphincter and impairs its function. In addition, gastric distension stimulates an increased rate of transient lower esophageal sphincter relaxation, thereby increasing the reflux rate. There are other contributing factors which help the lower esophageal sphincter to function properly. The esophagus enters the stomach at an acute angle, thereby creating a flap valve-like situation. The walls of the intra-abdominal section of the esophagus is compressed when there is positive intra-abdominal pressure, thereby keeping it closed. The folds of the mucosa, one has to remember that the mucosa is a longitudinal tube which is lined by mucosa, and it has to undergo contraction and relaxation. So the lining is in excess because it has to expand during swallowing. So when the esophagus is empty, the mucosa forms a rosette-like opening from the rosette at the lower end of the esophagus, which prevents reflux of gastric contents into the esophagus. And the right crest of the diaphragm has a pinch cork-like action, which further helps the lower esophageal sphincter to function adequately. So when a patient takes a large meal, there is repeated stomach distension. This causes shortening of the lower esophageal sphincter. This shortening because lower esophageal sphincter and incompetent sphincter, and then the reflux will occur. If you see this picture, you will understand that the longer the length of the esophagus in the abdomen, the less is the pressure. So less the abdominal pressure has a longer length of esophagus to compress and thereby prevent regurg. When the stomach is distended, then the intra-abdominal esophagus is also decreased, and thereby more pressure is required by the lower esophageal sphincter to prevent regurgitation. This is what is nicely explained in this picture. The general incidence of gastroesophageal reflux disease is about 20% with severe. But if we consider the people who have milder symptoms, then the incidence is goes up to 40%, and it is equal in males and females. The gastroesophageal reflux has the GERD has an iceberg phenomena. Mild symptoms do not seek medical attention. Frequent symptoms are seen by primary care physicians. Chronic persistent symptoms and complications are seen by the gastroenterologist, and the surgeon really gets to see the tip of the iceberg. So not many people will forthcome. They will think it is a routine and nothing abnormal and will not seek medical care. So the number of patients that we see is very few. Now, what is the relation between hiatus hernia and GERD? Hiatus hernia as a consequence of long-standing GERD. So because of long-standing GERD, it is chronic disease. There is shortening of the esophagus. There is loss of dilatation of the lower end of esophagus, which leads to dilatation of the hiatus, and thereby with decreased and repeated distension of the stomach is pulled into the esophagus, pulled through the hiatus into the chest, and with long-standing and further deterioration in the muscle tone, the stomach will get pulled into the stomach. The stomach will come to lie in the chest, and therefore this is how GERD itself can lead to hiatus hernia. Here you can see that LES pressure is often low. Gastric pouch is intrathoracic. So here, by sheer presence of the stomach into the esophagus, that is abdominal organ in the abdominal place, will give rise to hiatus hernia, and there is no esophageal pinch because the hiatus is enlarged. So this is how hiatus hernia can be produced by reflux, or it can coexist. Clinical presentation, you can have classical GERD presentation. Either you can have extra esophageal symptoms or typical symptoms of GERD and complication of GERD. We will deal in depth with these things as we go further. Now, what are the red flag signs in GERD? New onset indigestion in a patient aged above 55 years, unexplained persistent vomiting, hematemesis, unintentional weight loss, progressively worsening dysphagia, odynophagia, exertional epigastric pain. And what are the symptoms of GERD? So you have esophageal symptoms and respiratory symptoms. So esophageal is persistent heartburn and acid regurgitation, belching, water brash, that is sudden excessive salivation, sore throat in the mouth, food stuck in the throat, the feeling of food having stuck in the throat, difficulty of pain when swallowing, and they also could have chest pain. The extraesophageal symptoms are due to the spilling of this gastric acid or gastric and duodenal contents through the esophagus into the respiratory tract, and then this patient can present with repeated hoarseness of voice, choking or throat tightness, chronic sore throat, dry cough, bad breath, inflammation of the gums, erosion of the teeth and enamel. So these are the extraesophageal symptoms. But here today we will be discussing the esophageal symptoms and not the extraesophageal symptoms in detail. The importance of diagnosing and treating GERD is that it is a chronic disorder, it is a lifestyle disorder, and it has a negative impact on health-related quality of life. Risk factors, it is also a risk factor for development of esophageal carcinoma, adenocarcinoma, if the patient gets Barrett's esophagus. Now, how do we diagnose GERDs? It is review of the symptoms and complete physical examination with special attention to alarming symptoms such as duration and severity of the symptoms, anemia, dysphagia, and weight loss. So these are the clinical symptoms on signs on which we can easily diagnose GERD. Now, we have to make differential diagnosis of GERD from irritable bowel syndrome, achalasia, polylithiasis, coronary artery disease, and psychiatric disorders. It is very important to make the differential diagnosis, because we are not able to do that will land us in a severe problem. Another thing is GERD has to be differentiated from angina pectoris, because in both conditions you get epigastric pain. So in GERD there is burning pain. In angina pectoris, it is gripping or crushing pain. Pain seldom radiates to the arms in Gerd. Pain radiates into the neck, shoulders, and both arms in angina pectoris. Pain in Gerd is produced by belching and drinking hot liquids. In angina pectoris, pain is produced by exercise. Pain in Gerd is released by antacids, relieved here by rest. Dyspnea is absent in Gerd, and dyspnea is present in patients suffering from angina pectoris. So, if we make a mistake in differentiating these two, we could really have a problem on our hands. Therefore, I have emphasized this slide in greater depth. Now, not all patients of Gerd need to undergo laboratory test or investigation. Heartburns and or regurgitation, postprandial, postural decrease with antacids. No diagnostic studies are needed. Just start empirical treatment, and if the patient responds, then this is a confirmatory test that this patient is suffering from Gerd. Now, when do we perform diagnostic tests? Is when the diagnosis is uncertain, atypical symptoms, symptoms associated with complications, inadequate response to therapy, recurrent symptoms, and prior to anti-reflux surgery. So these are the conditions where diagnostic tests must be done. Now, what is the goals of diagnostic evaluation of possible anti-reflux surgery? We have to find out that these symptoms that the patient comes with are present in many other conditions, and we cannot rely upon these to say that the patient is having GERD and subject him to surgery. So, to determine that gastroesophageal reflux is the underlying cause of the patient's symptoms, to evaluate the status of esophageal body and occasionally gastric function, to determine the presence or absence of esophageal shortening. So, these the goals of diagnostic evaluation are these, that we must find out and ascertain, confirm that the symptoms are due to GERD itself and nothing else. The diagnostic tests which will help us to clinch the diagnosis are barium studies. They are traditionally have been doing them. Endoscopy also is there for quite some time. Esophageal manometry, 24 pH monitoring. These are the new armamentarium in the surgeons with the surgeons to make a proper diagnosis of GERD. Barium swallow, it is the first diagnostic test for patients with dysphagia. It will tell you about the structure, its location and length, mass, location and length, hiatus hernia, size and type, as you can see in the pictures. And limitations of barium swallow are that detailed mucosal examination for erosive esophagitis, Barrett's esophagus, is not possible just by doing a swallow. So we have to subject this patient to endoscopy, and the indications for endoscopy are if the patient has alarm symptoms, he must be subjected to endoscopy. Empirical therapy has failed, so these patients also must be worked up. Preoperative, if you have decided to operate a patient whom you have confirmed diagnosis of GERD, but preoperative elevation, it is mandatory to do endoscopy. And detection of Barrett's esophagus. These are the conditions where endoscopy gives us a lot of information. These are the two videos which show you that there's a lower one. You can see the laryngitis, that is extra esophageal symptoms of GERD. You can see in the lower picture, the stomach is getting pulled up into the esophagus. You also see longitudinal mucosal ulcerations in this esophagus. In the upper, you can see the Z line, and the stomach is more than 2 or 3 centimeters into the esophagus. The Z line is towards towards us. And when you do the J maneuver, you can see that there is a crura are widely separated, and there's a wide gap between the scope and the esophageal hiatus. You can see the crura which are lax. See the stomach coming into the esophagus. Another thing that one will see on this endoscopy is a platulous gastroesophageal junction, and you can also see that because of the stomach comes repeatedly into the esophagus, there is prolapsed gastropathy. The stomach collapses into the esophagus and gets some mucosal hemorrhages, which is labeled as prolapsed gastropathy. Here you can see a small sliding hiatus hernia. The gastric folds are extending for more than a centimeter above the diaphragmatic closure during inspiration. The squamous column of the junction remains distinct and it is quite proximal. The other entity, that is endoscopic negative reflux disease. Now this is a condition where the patient has symptoms of GERD but does not have esophagitis. So these patients are labeled as endoscopic negative GERD disease, and one has to be careful while doing surgery on such patients. On endoscopy, we can find out the severity of the esophagitis, and Los Angeles classification is a very good method of classifying from A, B, C to D, and you can see the corresponding pictures and severity of the disease. So as you go from A to D, the severity of esophagitis increases, and this is very good tool to have uniformity to describe the esophagitis, to compare and describe the esophagitis that one sees on endoscopy. Another thing that is handy, and it is a new addition to our armamentum, is the manometry. And the indications for manometry are dysphagia after exclusion of a structural lesion. The patient has no structural lesion, he had dysplasia, so one must do manometry to find out the esophageal peristalsis and whether the lower sphincter relaxes or not. Chest pain of suspected esophageal origin, what we call as non-cardiac chest pain, is a good indication for manometry. We would also like to localize the lower sphincter before doing a pH monitoring, for which manometry comes handy. Further characterization of motor dysfunction detected on Begum's radiography. You have seen some abnormality on radiography which can be confirmed or ruled out by doing manometry. Preoperative evaluation of anti-reflux surgery. I do manometries in all patients before I do a fundoplication for various reasons, and confirmation of effect of treatment of lower sphincter, especially when we are operating for achalasia, or even some people do routine manometry at the end of fundoplication to find whether the lower sphincter has improved or not. Or this can also be used as a during the follow-up period to find out the effectiveness of your wrap. So here you can see the normal esophagus, you can see the normal wave in the first picture, that normal subject. Hiatus hernia, you can see the diaphragm level, diaphragm position is much lower down, and the esophageal sphincter is higher, it's above the diaphragmatic hiatus, and this is the classical example of hiatus hernia. The last picture is that of absent peristalsis, that is achalasia. If so, we can tailor the wrap. Some people would like to tailor the wrap depending upon the manometric function, though the issue is controversial and there is no convincing evidence to say that you have to tailor the wrap. If the other two tests do not give us proper information, or we still have some doubt, then we have ambulatory 24-hour pH monitoring. The significance of this test is that it correlates the symptoms of the patient to pH level or upon the acid level in the stomach. So it is a physiological study. It quantifies the reflux in proximal and distal esophagus. Percentage time of pH less than 4% should not be more than 5% in 24-hour period. So this will give us exactly what is the percentage. D-Messeter score normally is less than 14.6, and in patients with reflux esophagitis or regurgitation, the pH will be definitely, D-Messeter score is high, and that is a good indication for us to operate these patients. So we have proper symptom correlation by doing a 24-hour pH monitoring. Here you can see in normal, the pH is below 4 in very few times, and so definitely it is less than 5% in the 24-hour period. But in patients with GERD, it is definitely more than 5%, and many a times the pH is below 4, and this is what is troublesome and causes symptoms. So why should we treat GERDs? There is acid pepsin duodenal contents which regurgitate into the esophagus, from the duodenum into the stomach, from the stomach into the esophagus, and this causes esophagitis, and esophagitis can lead to Barrett's esophagus, and it can also cause strictures. So GERD has to be treated because it creates complications. It creates esophageal ulceration, esophageal stricture, non-iron deficiency anemia due to recurrent bleeding. It can cause Barrett's esophagus. It also, we know that extraesophageal symptoms such as laryngitis, laryngeal ulcers, bronchial asthma, aspiration pneumonia are quite common with those suffering from GERD. Now, because of repeated exposure of the lower end of the esophagus to the alkaline and alkalines and acids, there is repeated exposure which leads to mucosal and intramural fibrosis, and this intramural fibrosis can lead to stricture formation. Then because of injury, there is replacement of squamous epithelium with column epithelium at the lower end of the esophagus. This is what we call as Barrett's. And in Barrett's esophagus or mucosa can undergo metaplasia, dysplasia, and it can lead to adenocarcinoma at the lower end of the esophagus. That is a good indication that GERD should be treated. Complications: acid damage, as you can see here, there is Barrett's esophagus in the first picture. There is esophagitis. Then this leads to dysplasia and can lead to adenocarcinoma formation at the lower end of the esophagus. So that is the danger of Barrett's esophagus. So the treatment goals for GERD are: we aim to eliminate the symptoms, we want to heal the esophagitis, we want to manage or prevent complications, and we want to maintain long-term remissions in these patients. So how do we go about? So we have conservative treatment. If that fails, then we will investigate the patient, and after investigation, we will treat them medically, and if they do not respond to medically or do not want medical treatment, they will be subjected to surgery. So the treatment is lifestyle changes, medical and surgical. Conservative management of GERD includes lifestyle modification, use of antacids, antacid suppressants such as H2 blockers and PPIs, and prokinetics are the latest additions, which are additional drugs which are available for us to treat GERD. Lifestyle changes, all of us know, if you smoke, stop smoking, do not drink alcohol, you must lose weight, not eat small meals, wear loose fitting clothes, avoid lying down for 3 hours after a meal. This is what we advise patients who are on conservative treatment. Raise the head end of your bed 6 to 8 inches by putting blocks of wood under the bedpost. Just using extra pillows will not help. So this is what we mean by change in lifestyle. Medications that are available are, all of us are aware of it: antacids, foaming agents, H2 blockers, proton pump inhibitors, and prokinetics are the newer additions which can be used to increase the motility of the esophagus, thereby increasing the clearance and reducing the damaging effect of antacid on the lower end of the esophagus. So PPI therapy can be initiated with once daily for 6 to 8 weeks, and it should be taken 30 to 60 minutes before meals. It is important to take it for 6 to 8 weeks because it takes about 6 to 8 weeks for the ulcers to heal, and the drug should be taken 30 to 60 minutes before the first meal of the day. Those patients who respond but recur after discontinuation of therapy, you can use tailored therapy or switch the PPI, change the PPI. Now those who have partial response, then you can increase the dose of the drug from a single daily dose to twice daily dose, or you may also alter the PPI. If there is no response, further evaluation like endoscopy or surgical management is indicated in these patients. One must remember that control of reflux is better than control of symptoms. PPIs suppress acidity and relieve symptoms but do not control reflux. Surgery is the only entity or methodology or mode of treatment that will completely eliminate reflux, because anti-reflux surgery eliminates reflux totally, and therefore the acidity is not there and the symptoms are also taken off. So the various anti-reflux procedures that are done are Nissen's fundoplication, Trupe or posterior partial fundoplication, Dor or anterior partial fundoplication, and Belzi-Mark fundoplication. Out of these four operations, Nissen's is the most commonly performed operation. Dor is performed only to prevent reflux after surgery for achalasia. All these procedures can be done laparoscopically. Indications for surgery: who are the patients? That is, those patients who are averse to lifestyle changes, those who have good response to proton pump emitters but do not want to continue with medication, complications of Gerd, stricture or bleeding, patients' preference for stopping pharmaceutical agents, and patients with airway manifestations of Gerd, such as extraesophageal manifestations of gastroesophageal reflux disease, also candidates for surgery. And patients with Barrett's esophagus, as I told you, Barrett's can lead to carcinoma, so we should operate them and prevent further damage of the esophageal mucosa. Those patients who have good response to proton pump emitters are actually a good test, or these patients will do very well after surgery for Gerd. Who to operate on? Patient selection for this is a lifestyle disorder, and therefore patient selection for anti-reflux surgery is the key for ensuring good surgical outcome. All patients who undergo anti-reflux surgery should have evidence of reflux demonstrated on pH studies. So you must have evidence about reflux and the symptoms before you can embark upon surgery. Patients with reflux symptoms and negative pH studies should be carefully counseled before embarking on surgery, because they may not get the desired relief. Gerd patients who wish to discontinue medical therapy may be referred for surgery, and there are patients with large hiatus hernia, reflux with respiratory complication and Barrett's. These are also good candidates who may be considered for surgery. When we choose a surgery, when we select patients for surgery, we have also to remember that there are long-term maintenance. In the long term, maintenance of PPI therapy is problematic. Anti-reflux surgery should be considered by patients with chronic symptoms or complications. Laparoscopy has significantly increased utilization of surgery because it is minimally invasive, and low threshold for referral to surgeons with upper GI and laparoscopic expertise. We must tell our physician friends to have low threshold for transfer so that we be able to do justice to our patients. Now, there are some drawbacks or complications or side effects, I would say, of fundoplication. Patients can have dysphagia in the postoperative period. They can have bloating, and they may require PPI long-term follow-up after a few years. We have to also remember that apart from the post-operative complications, intraoperatively also we could have complications that we do have common in any laparoscopic procedure. In this, we can have perforation of the esophagus. In Gerd surgery or Nissen fundoplication we are doing, we could have pneumomediastinitis, we could have esophageal tears, gastric tears, we could damage the liver. So we have to be extremely careful. Having decided to do surgery, what are the anti-reflux principles of anti-reflux surgery? We want to obtain a high pressure segment of intra-abdominal esophagus. So the reflux greatly depends upon the length of the esophagus, is intra-abdominal, and we should be able to create a pressure which is more than 12 millimeters of Hg at the lower end of the esophagus. That is the physiological sphincter, LES. And we must enter at least 3 centimeters, because the greater the length of the esophagus in the abdomen, the less intra-abdominal pressure is required to prevent Gerd, because longer the length, less pressure is required, and if it remains compressed, then less reflux is likely to occur. Laparoscopic Nissen's fundoplication creates a 2 to 3 centimeter long tissue bag, that is complete wrap of the gastric fundus around the distal esophagus, and the long-term success rates are best with this operation, and they reach the figure of about 80 to 90%. This is what we achieve. We restore intra-abdominal length of the esophagus, which is 2 to 3 centimeters. Then the cura is approximated after having reduced the hiatus hernia, and we perform a fundoplication so that the wrap doesn't migrate, and it also compresses the lower end of the esophagus and increases the lower end LES pressure. Now, how does fundoplication work? There is increase in the lower LES pressure. Total fundic wrap reduces postprandial reflux by reducing transient lower vessel sphincter relaxation and rendering swallowing induced relaxation incomplete, prevents shortening of the lower vessel sphincter during gastric distension. Correction of the hiatal hernia improves esophageal clearance and diaphragmatic function by enhancing LES pressure. And fundoplication also improves gastric emptying, thereby increasing length of the esophagus and keeping the stomach empty. So this is Nissan's fundoplication. You might have seen this for yourself. Now, what is the going into the details of the operation? Patient position and setup. Patient is in supine position. This is done under general anesthesia, a Rice tube, empty stomach, a Foley's catheter if preferable. Then the surgeon stands between the legs of the patient and works with both hands using a 30 degrees. If you have a 40, it is a luxury, and a reverse tensional position about 15 to 20 degrees depending upon the body habitat of the patient. This slide shows you the positions of the various trocars. The camera port is about 4 fingers breadth, 4 centimeters above the umbilicus. Then you have right and left surgeons, left hand port and the right hand port, and the liver retraction. If you have a nathesis resector, it is of great help in helping you to retract the liver, and the assistant port is on the left flank of the patient. So these are the port positions for laparoscopic fundoplication. I will show you a short video where these things are even made more clear. This is a 23-year-old male patient, diagnosed with hiatus hernia. His complaint was persistent epigastric pain and retrosternal regurgitation, not relieved with medicines for 2 years. Gastroscopy was done. So all patients must undergo gastroscopy and 24 pH or at least manometry if there is any further doubt. This is the J manual, you can see. This is the manometry. You can see there is a double wave pulse, double sign in this. This is the laparoscopic picture. You can see the liver is nicely retracted up. This is the OG, we are just on the stomach, and you can see the cura are widely separated and the stomach is easily going between the cura. So this is quite a big hiatus hernia. The operation starts with division of the falx placida so as to expose the right crus of the diaphragm. Here you can see the right crus of the diaphragm. We try to save the peritoneum or keep the peritoneum, the right crus intact, and I am taking incision just on the inner aspect of the right crus or the cura. Harmonic scalpel is of great benefit. It makes your job very simple. Here I am trying to make, you can see the right crus, the left crus, and I am trying to make a retroesophageal window just below the left crus. Then I move on to the left side and divide the phrenicoesophageal. This is the phrenicoesophageal ligament. Here also I will try to keep the peritoneum on the left crus, left cura intact. We have to take care that we do not damage the anterior vagus nerve. And the aim is to separate the esophagus from the left crura. Here you can see we have gone onto the other side. You can see the right crus, the left crus, and we have made a retroesophageal window below the left crus, and we'll be soon able to see the fundus of the stomach over there. Then at this stage, I'd like to pass a tape into this retroesophageal window, taking care that you don't damage or puncture or inadvertently puncture the spleen. Here, once this is done, then you can enlarge this window. The tape is tied around the OG junction. You can use a Foley's catheter as some people use it. And once that is over, the window is large enough, I move my attention to mobilization of the stomach to a greater momentum is to be divided, and the fundus of the stomach is to be mobilized. Here, I start halfway between at the greater curvature, and I'm going to divide the short gastric arteries right up to the last short gastric. Many people believe that this is not necessary, but I believe, and there are many studies which have proven that it is always better to mobilize the fundus of the stomach nicely so that you get a nice floppy and wrap, a nice floppy wrap. Some adhesions from the stomach to the posterior wall of onto the pancreas also need to be divided so as to mobilize the fundus adequately. So there is a big retroesophageal window. The stomach is coming, the fundus of the stomach is pushed and brought onto the right side of the esophagus, and then I am seeing whether it is adequately mobilized or not by doing the shoe shine maneuver. Yes, I have got ample stomach, fundus is mobilized. Once that is over, I have forgotten to show you the vagus nerve. It is just there at the lower. I have taken the posterior vagus along with the esophagus itself. Now here I am suturing the crura together. One must see that if they are thin, one may have to use the flagets so as to prevent cut through. Here black silk has been used, but Sutopac, Tujo Sutopac is a very good material. I have just taken 2 stitches. It is loose enough that one 5 mm instrument can easily go between the esophagus and the closed cruras. Then once having closed the crura, the stomach is brought onto the right side, the fundus is brought onto the right side, and then we are taking the first stitch, which goes from the fundus on the left side through the esophagus to the fundus on the left side, and this is tied. So we have taken 2 stitches. We should have 1.5 to 2 centimeters of the wrap of the stomach around the esophagus. Anything more may not be, it may be counterproductive. Once this is over, then I will take a stitch from the right side of the fundic wrap onto the right crus. So that is what I have done, and that is how I do my all fundations routinely. Now, talking about the results, outcomes, immediate and complete heartburn control is found in more than 90% of the patients. Excellent relief of regurgitation, water brash, and respiratory symptoms is achieved. Very effective response of postural and nocturnal symptoms. Significant improvement in quality of life. Decreased incidence of malignant transformation is claimed. We don't have enough evidence to support this statement. Then side effects or complications. These patients, the fundus wrap creates a one-way valve, and therefore these patients cannot belch, cannot vomit, and then these people will have gas bloat. So we have to warn these people beforehand about the symptoms of gas bloat, inability to belch, and inability to vomit. Then post-operative dysphagia may be there in 2 to 5% of the cases, but in about a month's time, this will clear off, and we don't have to worry if we have technically followed all the tips that are to be followed while doing the fundic bag. And because they cannot belch, their stomach gets bloated, and they tend to have more flatus because belching is not possible. So morbidity, there is gas bloat, dysphagia, there is a fear of recurrence, and some people may require PPIs after few years of anti-reflux surgery. So this is a lifestyle disorder, and therefore we have to see that we do technically perform a good fundoplication and do not give any chances for any mishaps, and we must achieve good results, for which we must select proper patient for surgery. The failure of anti-reflux surgery can occur. Now, there could be reoperation rate. There's a reoperation rate about 5%. The main reason for failure is poor patient selection. Be extremely careful while selecting a patient for surgery. Otherwise, they will pester you throughout your life and they become miserable, and they will make you miserable and portray you as a bad surgeon. Failure to recognize delayed gastric emptying. This is one must find out whether there is delayed gastric emptying. Then short esophagus may be one reason why there is failure of the surgery. Large hiatus hernia, esophageal dysmotility. That is why manometry may be helpful at times, and poor surgical technique. This is the surgery results depend a lot upon the surgical technique, and therefore one should properly acquire the expertise of performing this operation so as to get good results. Common surgical pitfalls that may cause problems are the fundus being wrapped around the stomach instead of the esophagus, incomplete esophageal mobilization to obtain 2 or 3 centimeters of the abdominal esophagus. So incomplete mobilization can cause problems. Incomplete mobilization of the gastric fundus, in my opinion, this can be best achieved by dividing the short gastric vessels. Incomplete crural closure or tight stitches leading to strangulation of the crural muscles, which will give way very soon after surgery. Therefore, one may use pagettes so as the stitches should not cut through. The other operations that are there are the Toupet, Dog, Belsey Mark IV, and Hills. But the most common is a Nissen's operation, which is performed by most of the surgeons. Now, there are some controversies regarding Gerd, and what are they as far as surgery is concerned? Whether routine short gastric vessel division, crural closure should be done or not, full wrap versus partial wrap. There's a lot of debate going about this. Use of bougie, whether you should use a bougie or not to close the before closing the crura. When do you need a mesh, and esophageal, what to do when there is esophageal shortening. So we will, in brief, I will sort out this. So the recommendations are when the fundus can be wrapped around the esophagus without significant tension, no division of short gastric seems to be necessary. But one has to remember, one cannot be dogmatic, so he will have to decide upon individual patient. But as a rule, I do division of short gastrics. I find that I don't have to modify my technique, even if I have to take a little longer time because I demobilize the fundus adequately to the wrap. My wrap is very floppy, and I would recommend that one should do division of the short gastric vessels in all cases. Whether the wrap should be for full wrap or partial wrap. There are a lot of studies, and both groups claim that there are best results with partial wrap or full wrap. But I believe that there is no need to tailor the wrap unless the esophageal peristalsis are totally absent, where one may do a partial wrap or one may do a Toupet operation, Toupet fundoplication. They all dysphagias, even if they're diagnosed preoperatively, have improved after total wrap, that is 360 wrap, the Nissen's fundoplication. They have got good results, and I feel no reason to tailor the wrap unless the peristalses are totally absent. Use of esophageal dilators, yes, many people insist that dilators should be used so that you don't make the crura very tight, but it depends. how comfortable you are with the anesthetic. Every time if you have different anesthetics, then there could be problems of esophageal perforations, and then I would rather depend on instrument. I would keep 5 millimeter instrument into the should be accommodated between the esophagus and the pleural closure. That I think is enough practically to say that the wrap is not too tight. Then when to use mesh? So where the hernial defect is large, if the hernial orifice is more than 5 centimeters, that is the indication for mesh. If the crura is thin and you are not able to approximate without tension or without tearing, one should use a mesh. And if there is a revision surgery, I think it is all the more mandatory to use a mesh so that you prevent the herniation or migration of the wrap into the esophagus. Various types and designs of these mesh are available. They should be, as far as possible, biological, or they should be bilateral mesh. Routine polypropylene mesh are not to be used in the vicinity of the esophagus. Crural closure. Anterior crural closure may be associated with less postoperative dysphagia, but additional evidence is needed to provide a firm recommendation. So if the height is very big, you may take a stitch or one stitch anteriorly. Rest of the stitches are taken posteriorly, and one should see that he doesn't change the angle of the lie of the esophagus. So friends, the take-home message that I would like to give you is surgery is the effective therapy for GERD. A nasal fundoplication is a procedure of choice. It provides the best control of reflux and commonly results in long-term dysphagia. Even in presence of clinical and or manometric dysphagia, a floppy nasal flybration is effective and can actually improve swallowing in many patients. So there is no need to tailor the wrap unless there are total loss of peristalsis in the esophagus, where partial wrap may be indicated. Thank you very much, colleagues, for the patient listening, and I am available, and you can ask me whatever questions you have or doubts you have, or point out anything wrong that I have told you. Thank you very much.